Hi everyone, it's Helene here from the PHN, and we have Jade, my colleague, in the background as well. Welcome to our radiology update this evening. I would like to acknowledge the traditional custodians of this land. I would also like to pay my respect to their elders past and present and extend that respect to other Aboriginal people present today. So welcome to the webinar. Just a little bit of information from our PHN. All our events are advertised on our website, and we do have a communique that goes out to all general practices across our PHN twice monthly, which includes a calendar of our internal events and external events. So if you could take the time to have a look at those, there's some really good events coming up. During the course of this webinar this evening, participants will be put on mute, and should you have any questions, could you type them in the questions box, and the questions will be addressed during question and discussion time, which will be at the end of each of the presenters this evening. So if you've got any questions during their talk, just pop them in the question box and I'll ask them on your behalf at the end. It'll all be anonymous, so you won't be identified at all. I'd like to take this opportunity to thank Lake Imaging for their ongoing support of our education program and their input into this session and providing the presenters. I'm just going to put up screen now our PHN health pathway. This is the health pathway relating to the topic that is on the screen. There we go. So if you wanted to go in and have a look at that. I'll now like to introduce the presenters. We have 3 presentations this evening. Our first presenter will be Dr Chien, Director, Radiology, Lake Imaging, Geelong, followed by Dr Stefan Khosh, Radiologist and Director of Nuclear Medicine, Lake Imaging, Ballarat, and Dr Maywash Rehan, Consultant Radiologist, Lake Imaging, Warrnambool. I will now hand over to Dr Chien to commence the presentation. Thanks, Chien.
Thanks a lot. I'll just launch straight into it, and I just wanted to thank PHN for this opportunity to help with the education series. So thank you very much. So my topic is going to be on MRI of the rectal cancer, which is fairly specific, but has a clear role to play in terms of the management of rectal cancer and the decision-making process in terms of treatment. And today's talk is really just to give an update on a recent consensus statement by the gastroenterology bodies from across the Europe and America in terms of approach and impact on management, and also to introduce the current concepts around management of the patient and decision-making for this condition. So I'm just going to run very briefly through the anatomy excuse me, and pathology of rectal cancer, and touch on how we acquire the images, and also on this consensus update as I've described earlier, or alluded to earlier, and spend a bit more time on the role of imaging and really what the surgeon, but also what the multidisciplinary team really needs to know in order to make that decision on treatment and management. And then I'll spend the second half of the talk on cases just to illustrate some of these pathways. So firstly, rectal cancer is predominantly adenocarcinoma, and most of which 95% are adenocarcinomas, and typically starting as a polyp or an adenoma. It's defined as rectal being in the distal 15 centimeters of the intestinal tract as measured from the anal verge. And adenocarcinoma is the predominant type. There are some types, mucinous and signet cell. Sometimes you see that come through in the pathology report. Those are rare, but are known to be more aggressive in their behavior. There are rare other tumors, lymphoma, gastrointestinal stromal tumors, GISTs, and leiomyosarcoma, neuroendocrine, etc., which I'm not going to cover on today's talk. So just looking at the anatomy, on the left here is a sagittal slice of an MRI, a T2 weighted MRI in the midline. just to show you what we look at on a day-to-day basis when we are assessing the rectum. So the light yellow is the mucosal surface. The slightly darker yellow is the submucosa. And in MR world, the submucosa and mucosa are very difficult to separate out. The orange line is the important line on imaging. That's the muscularis propria, or the muscle layer, and we'll spend a bit of time, I spend a lot of time looking at that line to see if there is breach through there, that muscular layer. This green reflection here is the peritoneum. The peritoneum encircles the rectum lower down, but as you go further cranially, it becomes more attached only at the front. And so this is an axial plane. You can see the seagull appearance, and again, that's an important differentiator for us when we're looking at the peritoneum in relation to any tumor. I'll just spend 10 seconds on this slide. It's more just a technical slide to say that in modern MRI imaging, we use a 3T machine, a 3-Tesla machine, and we scan in high resolution in 3 planes. In the T2 weighted sequences, they are real workhorse sequences. We do diffusion and sometimes some other kind of sequences, but that's really the standard. This is the consensus article I refer to, and it's a very in-depth article, but essentially it's a literature review that looked at over 200 separate points or items to try and get a consensus on how to prepare the patient, on what sequences to do, how to evaluate tumors, and on a reporting standard. So this came out in 2018 and really updated the work that was done by largely the same group in 2012. So again, a lot of this is technical, but I'm just going to go down to the important parts, and this will be broken down step by step in the forthcoming slides, so don't panic to see so much writing. But essentially, the key thing that we need to work on is that has updated us is in terms of consistent reporting of the T3 and T4 substages and how to differentiate those, and I'll go through that briefly in the next few slides. This concept of EMVI, I'm sorry, I should have written that. That's extramural vascular invasion, so the vessels next to the tumor. Sorry, I'll just go through that. Missed that last point. And specific reporting of the nodes, which is another area there's been a significant change. So staging and MRI. So MRI, basically, one of the take-homes here is that MRI can't reliably distinguish T1 and T2 tumors. So basically those that are just in the mucosa, submucosa complex, or just into the muscularis layer. We're not reliable. Endorectal ultrasound may have a role there. It is pretty reliable in differentiating T2 and T3 tumors, so those that are just poking beyond the muscular layer, and as opposed to just respecting that boundary. And that's important in terms of stratifying which way we go in terms of treatment. And the T3 tumor staging, there's 4 A, B, C, and D. Really, we group into good or early T3, which is A and B, which is less than 5 millimeters beyond what we imagine is the muscularis propria, and then not good, which is more than 5 millimeters, which is stage C and D, which so really that's the key difference, 2 points. And you can see here, this is an example where we have a T2 axial MRI. This is what we would see as a smooth black line for the normal muscularis propria. You can see here it's broken, and you've got this nodular stranding, which is indicative of T3 disease. Again, another example there. So just the other important structure here is called the mesorectal fascia, which is this line around here in between muscular tube of the rectum. There's fat, and then this line. And this is important because this is the resection plane for surgery. So we really want to know whether the tumor has gone, if it's gone beyond the muscular structure, how close it's gone to this line. So if it's within 2 millimeters, it's called threatened, or if it's 1 millimeter or less or involved, then it's involved. And that's important in terms of the type of staging. T4 is quite advanced tumor, and that's subdivided into A and B, basically peritoneal structure, visceral peritoneal involvement or other structures in the pelvis. This is again a complicated slide, but really just to say that in the low rectum, as sometimes you get these rectal tumors are very low. This is a really tricky area for us because the internal sphincter, which is this dark brown wall, blends with the external sphincter, and you can see this plane between the intersphincteric plane becomes almost nothing. And so the difference between a T2, T3, and then into a T4 is very difficult sometimes to assess. And this has always been a difficult area, and there hasn't been a lot of consensus. So we just tend to report anatomically what we are seeing. That's the one area the consensus statement didn't come to a consensus. Again, lots of detail here, but essentially with lymph nodes, there are certain criteria. Size is a big one, so if it's more than 9 millimeters, we always think it's somewhat suspicious. If it's less than 9, there are at least 2 or 3 of these morphological features: the shape, the border, and the signal that needs to be heterogeneous and irregular. And the nodes, the red nodes here are really just indicating nodes which are considered outside the local regional nodes, and they're considered metastatic. And these are important from the radiation oncologist perspective. They want to, because that would mean they include those in the field if they're involved. As I mentioned, involvement of vessels that are in the area around the tumor, in the fat around the tumor, is a prognostic indicator. So that's now recognizing we have to routinely report, and it conveys a higher risk of local recurrence and distant recurrence. So what does the surgeon want to know, or what does the MDT want to know? It's been well established now that MRI gives you an ability to reasonably accurately stage the T2, T3 in particular, and T4, and also to identify the circumferential resection margin. It does help us guide the algorithm. So as we said here, preoperative chemoradiotherapy, or to plan for surgery if it doesn't look like the margins are involved. And there's been long course chemoradiation has been used to downstage locally advanced cancer before surgery. And both, many trials have shown long and short course radiotherapy to reduce local recurrence. So why are we bothering if it's well established? Well, I think one of the things we're working towards in 2020 is to understand that some patients may potentially be overtreated, and so we're trying to identify those that can avoid having excessive exposure to long-term toxicity associated with neoadjuvant treatment. And that's one of the things we're trying to refine. So this slide here is again complicated, but essentially in terms of the decision making, we come down to this section here, where we've got important input from the general practitioner, surgeon, oncologist, radiologist, pathologist, nurse coordinator, and other allied health at the MDT, taking into account these broad factors in terms of operative risk, cost, social and potential benefits versus risk therapy. And so the idea is to work out whether there is an intent to, or whether there's value in adding neoadjuvant therapy with a bridge to surgery in terms of downstaging. So I'll just concentrate on these two limbs, the good and the bad. I guess I'll expand on those, but essentially prognostically good and then the less good. But there's also an arm, and we have had a few patients going down this alternate arm where the surgery may not be an option for a variety of reasons. So there is therapy, chemoradiotherapy given with a view to curative or to watch and wait. So what's good? Well, CRM is clear, or certainly in this case threatened, but essentially that we have confidence you can get a clear margin, no nodal disease, no vascular invasion, and a higher tumour generally. And good prognosis, survival 85 to 90% 5-year. And most of these tend to go to surgery without neoadjuvant therapy. The less good or bad, traditionally it's been T3 or T4 and no positive, which still fits. But if there's a threatened CRM, if it's low and near the anorectal junction, there are nodes outside the resection margin, or there's a vascular invasion, all considered in the not so good category and often would point you towards neoadjuvant therapy. And then the alternative group, which are, as I said, maybe any one of these, but where there is a consideration to go down this alternate route of neoadjuvant therapy as a potential cure. So this first case is a patient who's 72 years old, had a positive fecal occult blood, and saw the gastroenterologist and had a colonoscopy. There was a anterior rectal polyp which was biopsied and came back as histology of poorly differentiated adenocarcinoma. So we did the MRI, and you can see here this is a sagittal plane on this side and an axial plane. This is the tumor here, here, which is not so well seen on the sagittal, but better seen on the axial. And this is a sessile, flat-looking polyp poking into the lumen. The white stuff is jelly. We put some PR jelly up to help with the differentiation. And you can see that the muscularis looks pretty intact. So this is considered a T1/2 stage with no nodes. So this is considered a candidate for transanal minimally invasive surgery, or TAMIS, without the need for neoadjuvant therapy. Patient had a follow-up MRI with no disease. You can see just some low signal fibrotic scar, which is often the case post-treatment, but without any sessile polyp or any nodular spread. Interestingly, there was something noted in the prostate, which was this lentiform low signal lesion here at the base of the prostate. And that patient had a separate evaluation with prostate MRI and turned out to be a prostate cancer. So luckily but unluckily in terms of a pickup. So the second case is that of a 48-year-old male with who had a colonoscopy on which there was a polyp, again biopsied and shown to be malignant. This one is much more sizable. It's this frond-like bulging polypoid lesion with a very short stalk. That's a sagittal lesion, and this, as you can see, it's the mid to upper rectum. Here it is in an axial plane, and you can see this lesion here, this grey lesion here, poking into the lumen of the bowel of the rectum. And another plane just to show you the same thing. So this is a tumor which has a very short stalk. These can be quite tricky to stage a little bit because you've got all this puckering in and looking for the line of the muscle can be tricky. But this is thought to be an early T3, possibly some nodular extension, but less than 5 millimeters, and no suspicious nodes. We ran a diffusion scan, which really just shows whether the cells are tightly packed, and more commonly shows this bright signal on a particular sequence or indicating tumor cells being more tightly packed. So this again lends weight to the fact that it's malignant. And had a staging CT, which apart from an incidental hemangioma showed nothing else in terms of distant disease, and progressed to a low anterior resection and had some adjuvant chemotherapy. So that patient's another example of someone that's gone down the good pathway with, and this patient would typically and did have a CT at 6 months for surveillance and has been doing fine. So the third case here is of a 79-year-old male with mid to upper rectal cancer. Now, again, I always start with the sagittal T2, which is this one here. You can see some jelly here. This is the thin, see how thin that pencil line wall is there? This is the wall which has become thick, and you can see it's actually on either side. The plane through in this plane, as it's called an oblique axial, cuts it in the short axis, so you can see muscularis propria, abnormal, thick, nodular, bulging. So this is already feeling like a not good lesion, and at least a T3C type lesion. This here is the peritoneal reflection. We want to tell them if it's above or the peritoneal reflection, and this one is. These are two nodes. We can see size and signal both qualify this for a suspicious node. And then along here, this is a vessel that's coming in and it's expanded, and so this is extramural vascular invasion positive. So this is a T3C node positive, EMVI positive tumor. So this is considered quite high risk. The patient has gone down the road of a neoadjuvant therapy as a bridge to surgery in terms of downstage, trying to downstage it. So following the MRI, so it's still T3, but the node was no longer identified. So it doesn't mean it was normal, but it's not MR positive from the node. So the final case I'm going to bring up is of a 63-year-old.
1 minute, Chien. 1 minute.
There's a low rectal cancer, which was staged as a T3A with one positive node, N1, a positive node. I think the social circumstances and decision after discussion was not to proceed to surgery, but instead to have follow-up, had chemotherapy and follow-up. You can see on the right here, here's the tumor, and then the restaging, it's become flat. And again, tumor on the right here, and this scar here. So this is a patient that, and then positive node here, and then resolve. So that's an alternate pathway. So in summary, we use MRI as a fairly powerful tool to try and identify locally advanced cancer, of which really bad T3 and T4 threatened resection margin, low and also vascular invasion are bad signs. As we mentioned, the resection margin is important, but the other points here are that lymph node assessment remains challenging, but it is important to try and find the nodes that are positive outside of the resection margin, because the radiation oncologist needs to know that. And finally, we refreshed our look at the neoadjuvant therapy pathway to include those that, apart from good and revising the bad criteria, those who may choose an alternate pathway using chemoradiotherapy as a potential cure rather than surgery in a small number of cases. Thank you. That's the end of the presentation.
All right. Thanks very much, Chien. That was a great presentation. Thanks for inviting me to speak, and to everyone who joined in today. My name is Stefan Khosh, and I'm a radiologist and nuclear medicine specialist, and I look after Lake Imaging's nuclear medicine services throughout Victoria. And today's topic will hopefully demystify nuclear medicine a little bit. And I find personally that understanding the underlying first principles in any matter helps to understand what we're actually doing when we image a condition, and that then helps us make decisions if the imaging modality is appropriate and how it can help us in diagnosis. So I'm hoping that after today's talk, you will have a greater appreciation and understanding of the usefulness and limitations of the bone scan. I've tried to structure this talk in a way that will hopefully be useful to your clinical practice without being bogged down in too much theory. So the points I'd like to go through with you today are what is a nuclear medicine scan in general, and how is it different to other modalities? Next, we'll have a look at specifically what a bone scan is and what it actually means when there's activity, and what kind of information we can glean from that. And then we'll look specifically at how a bone scan can help in diagnosis and management of painful conditions. So I'll go through several cases to help illustrate and consolidate that. And after that, I'm happy to answer some questions if there are any. So although we often think of medical imaging as a single broad subject, it helps to understand that each imaging modality has vastly different characteristics and looks at very different aspects of the underlying structures that we're imaging. So for example, with a CT scan, we shoot X-rays through the body and pick up how many got through at the detector on the other end. And this gives us an indication of how dense structures are. This is then represented as a grayscale image, with black being the least dense, which is air, and white being the most dense, such as bone and metal, if there's any. An ultrasound, on the other hand, doesn't measure density as such, although it can look very similar to the CT, but it measures how reflective tissues and especially tissue interfaces are. And that's why, for example, ultrasound cannot penetrate air, because at the tissue-air interface, all the sound is reflected back. The MRI works completely different again by allowing us to image proton density by using magnetic field and radio frequency. The nuclear medicine scan, although using radiation similar to the plain X-ray and CT scan, works different again. So here in this example, you can see how an X-ray beam penetrates the patient and is picked up at a detector on the other side. And this would be, for example, in an X-ray or a CT. The nuclear medicine camera, or we call that sometimes a gamma camera, images the radiation that comes from within the patient. So once injected, the radiation is greatest in places that the radioactive substance has concentrated. So here you can see that in effect, the patient becomes the X-ray source, and specifically the point at which the tracer is concentrated in the patient, like the chest in this picture. The detector picks up where the radioactivity is the most concentrated. So we're not really imaging the density of the tissue, although we are using X-rays, but in fact, we can measure the function of a tissue and the real-time movement of radioactive substances through the body. So the next question is, how do we make use of this and allow us to image very different processes in the body? So most nuclear medicine scans use a combination of a radioactive tracer and a physiologic molecule. So this allows for the variety of imaging of physiologic processes in the body. So here you can see that it actually is the physiologic substance that determines where the radioactive tracer is concentrated in the body and which physiologic pathway it allows us to image. So the radioactive tracer can be the same, but the physiologic substance is different. So you can see a sample of different physiologic processes that we commonly image, and I'm sure that you might have used at least one of these to help diagnose your patients. And of the above scans, almost all of these use the same radioactive tracer, which is technetium. We can also use other tracers, but they're a little less common. The notable exception, of course, is the PET scan, which uses a different tracer that requires a different type of scanner altogether, because it's based on an antimatter-matter interaction in the patient, which then produces the radiation. The list of things that we could in theory image is only limited really by imagination and technological progress. So for example, one of the latest nuclear medicine scans allows us to image a cell surface receptor in prostate cancer using a PSMA PET scan or prostate-specific membrane antigen scan. And the hope is, of course, in the future that we can become more and more specific in using antibodies, which are then tagged with the radioactive tracers and allow us to image very specific things like cancer subtypes. So I just wanted to address a common question that I get with nuclear medicine tests, which is around impaired renal function. Because the amount of tracer that is injected is minuscule and radioactive tracer decays naturally, there is really no concern with doing these tests in patients with renal compromise or failure, which is sometimes a question, is this like the CT or MRI? And it is not. So the bone scan uses a physiologic molecule called a bisphosphonate, which is incorporated into the hydroxyapatite during the osteoblastic bone forming process that bone constantly undergoes. So bone is constantly being resorbed and laid down, and different physiologic or pathologic processes can influence this balance. That's why on a bone scan you can see the skeleton, even though there may not be a pathology, and this represents physiologic activity. So the bone scan images the laying down of new bone by the osteoblast. It's important to remember that the bone scan does not image a specific process, such as a cancer or fracture directly, but it images the bone response to the pathologic process. So for example, if a cancer is very aggressive or a fracture very early, you might not see it because either the bone is broken down much faster than it can be laid down, or it has hasn't had yet a chance to mount a healing response. So, for example, would be multiple myeloma, which due to its very lytic nature is not well seen on a bone scan, and you can see an example here in this area, which is kind of a lower activity. On the other hand, once a lytic cancer process is treated, as it starts healing, it can become much more active, although the response to treatment is actually positive, and this is what we would call a flare response. So, so we've got a few more tricks up our sleeves with the bone scan. We can use timing for more information. So there are generally 3 phases or time points that we can image a patient at. The first is what we call the flow phase. This is equivalent to an angiogram, where you're basically imaging the radioactive tracer within the bloodstream during the first minute. So any process that is hypervascular will show an increase in transient tracer accumulation. So here you can see on the left multiple images which represent 5-second intervals, and you can see a point in the left foot where tracer accumulates focally. The next phase of the scan is called the blood pool scan. This is basically done a few minutes after the flow images and visualizes tracer that has diffused into tissues or intercellular space based on capillary permeability. And we know that in inflammation or in some cancers, there's often greater capillary permeability. So up until this point, we're basically imaging blood flow rather than the osteoblastic activity. In the final phase of imaging, which is the delayed scan, which is usually done around 2 to 3 hours or later after the injection, images the process of osteoblastic activity or the laying down of new bone, as we discussed before, and you can see the focus here. Although this gives us a great deal of physiologic information, there is a problem of accurate localization. When you look at what we call planar or 2-dimensional information, similar to an X-ray, it can sometimes be difficult to localize the point of activity in space. This is the same issue of seeing a density on a chest X-ray and then doing a CT scan to get 3D localization. The nuclear medicine equivalent to a CT scan is the SPECT scan, or single photon emission computed tomography. So as you can see here, we image slices of the patient and then combine it into a 3D representation to help with localization. But of course, somebody had a bright idea and wanted the best of both worlds of getting anatomic information and functional information and superimpose them onto each other. And this is how we got the SPECT CT scan, which uses a very low dose CT to give anatomic localizing information. So the scanners we nowadays use are hybrid scanners that can do both a CT scan and a nuclear medicine scan to help gain greater clinical certainty. So in this example, we can now know with certainty that there's activity in the base of the left third metatarsal, and in conjunction with the other phases of imaging, we can confidently diagnose a stress fracture rather than, let's say, activity in the joint and arthritis. Now let's look at some cases to hopefully drive home a few of the points we mentioned so far. The first case is a patient with heel pain. The planar or 2D bone scan showed some asymmetric increased osteoblastic activity at the right hind foot. The SPECT CT demonstrate increased activity at the plantar fascia insertion. This indicated active burnt bone turnover and suggested plantar fasciitis and active enthesopathy. One point to note is that the low-dose CT that is performed is not of diagnostic quality, but can give us some useful anatomic information, such as calcaneal spur. As you can see, spurs do not necessarily mean active inflammation. There is an Achilles spur here, which is not active. The blood pool images can also be used to give us an idea of the degree of inflammation. So the next case is a patient with severe right neck and shoulder pain. So we have a focus of increased activity, which maps to the right mid-cervical spine, as well as the right distal clavicle. On the SPECT CT, the activity maps to the right C4/5 facet joint and the right acromioclavicular joint. This helps in determining where cortisone injection might be the most effective, especially because most spines that we image anatomically with CT and X-ray will often have multiple degenerative abnormalities, and the bone scan simply helps localize where the process is most active and where it is not. So next case is a patient with chronic back pain, and especially with patients that do not have neurological symptoms but present with multiple degenerative changes on X-ray or CT. The bone scan can help differentiate between burnt out or non-active degenerative changes or ones with active bone turnover, which is an indirect sign of adjacent inflammation. So this scan localizes the right L4-5 facet as the culprit, and the patient was successfully treated with a facet joint cortisone injection. So this is another patient with back pain, and in this patient, the activity was mainly in the end plates of L4-5 and not in the facet joints, again helping differentiate patients that would benefit from cortisone injection to those that probably wouldn't. This next case is a patient with chronic back pain that got worse in the last few weeks, and here we can see activity in both the superior end plate of L2 and L3, and you might appreciate that the activity in L3 is stronger than L2. The SPECT CT shows an L2 end plate compression fracture as well as a mild compression fracture of L3. However, the increased activity from L3 means that the fracture is still healing and therefore more acute than L2, which looks worse structurally, but has almost finished healing and was probably acquired a while ago. So it helps us with time of fracture. And in this setting, we can also use blood pool imaging to look for more active inflammation to help determine the age of the fracture. So this next case, the patient had lower back pain, more on the right, on a background of psoriasis. Here we can see activity in both L4 and L5 facet joints, as well as within the right sacroiliac joint. And this activity in the joint suggests sacroiliitis rather than a sacral fracture. The lower lumbar facet joint activity is obviously consistent with active facet joint arthropathy. So that helps localize. This next patient is a patient who has chronic pain in the right hip and thigh for several months. He's had a right hip replacement 10 years ago. So the first two images are taken in the blood pool phase and demonstrate increased activity in the left proximal femur. And the delayed images also demonstrate increased bone remodeling surrounding the femoral prosthetic component of the prosthesis. The SPECT CT gives us more information of where the prosthesis ends and where the activity is in relation to it. So this is consistent with loosening, as the prosthesis can rattle around in the cavity and cause an increased bone response. This next case is a patient that presented with pain in the lower back and buttocks after a fall a few weeks ago. The X-ray was normal, but here we can see activity in the distal sacrum and coccyx region. And on the SPECT CT, this maps to the distal sacrum and sacrococcygeal joint and indicate an undisplaced fracture. This is an elderly patient with a minimal fall and pain in the lower back. And here we can see activity that localizes to the bilateral sacral ala and mid-sacrum, and is therefore consistent with a sacral insufficiency fracture. And this is what we sometimes call the Honda sign because of the H. This is a patient with an old right hip replacement that had a fall and has pain. And the question was whether the prosthesis had loosened. So the scan showed that the scan showed that the femoral prosthetic component had no abnormal osteoblastic activity and was therefore not loosened, but there was focal activity in the right acetabular wall, which, although normal on prior CT, indicated a non-displaced fracture. So here is an interesting case of a patient with wrist pain that actually didn't have much osteoblastic bone abnormality, so I didn't show the delayed images, but had increased activity on the flow and blood pool imaging, just here in the medial portion of the wrist within the soft tissues, and this was consistent with the Quervain's tenosynovitis. This is a patient with breast cancer in remission that presented with right-sided chest pain without a history of trauma. So a single rib focus of increased osteoblast activity was seen in the second anterior rib, which on the SPECT CT correlated with the healing fracture rather than metastasis. So this is another area where the SPECT CT was quite useful to help us differentiate. For this patient, the back pain was unfortunately the result of bone metastases, as you can see here, throughout the spine and pelvis, as well as underlying pathologic fractures. And even if the fractures are seen on a CT, the bone scan can still help to visualize the extent of metastasis and can help us make us aware of areas of risk. So for example, if the right femoral neck metastasis, which you can see here, gets bigger, it could lead to pathologic fractures. So this is a patient that's had a fall from a ladder a few weeks ago and presents with ongoing chest pain. The scan shows a linear distribution of osteoblast activity along the right-sided ribs consistent with fracture. There's also an incidental sternal fracture identified, which you can see on the SPECT CT. Sometimes the bone scan can show bony changes earlier than structural changes. So this patient had right hip pain with only minimal changes on X-ray. And the bone scan confirms active bone turnover in the weight-bearing part of the hip joint consistent with early osteoarthritis. This is a young athlete that has shin pain. And what you can see is that there's on the blood pool imaging focal activity as well as bone turnover within the region of the tibial tuberosity seen on the SPECT CT. And this was consistent with Osgood Schlatters. And there's also some very mild changes developing on the other side. Another young athlete with shin pain. This time there's activity along the anterior tibial cortex in a linear fashion, which you can see on the SPECT CT, which is considered consistent with shin splints, which indicates underlying bony stress reaction, which leads to increased bone turnover. So this is a similar patient that had symptoms and didn't listen to their GP to take some rest and continued. And as you can see, has activity in both tibia in a linear fashion, but also now demonstrates this focal area of activity within the right mid tibia, which you can see here, which has now turned into a proper stress fracture. So in summary, the nuclear medicine test visualizes physiologic or pathologic processes. The bone scan visualizes the laying down of new bone, which can be increased due to many causes, including trauma, cancer, infection. And it's important to note that it doesn't actually image the actual insult, but it looks at the bone's response. If a process is purely lytic or destructive, it may not be seen on a bone scan. But an absence of activity can also be useful to include a significant disease process. So in the case before, as we saw, for example, is the question, is there loosening or not? Or is something just a bone island, or is it a tumor? And we can use SPECT CT to improve the localization of areas of activity. And the bone scan can be helpful to localize and diagnose painful bony and joint conditions and help in the management process, such as suggesting if something may be amenable to a cortisone injection or not. And then the bone scan can also often pick up changes earlier than structural imaging, such as X-ray or CT. So they could be normal on those modalities, and we can find some abnormal bone turnover. So I hope that I've been able to shed some light on the underlying principles and functional processes we use every day, and also provide you with a better understanding what a bone scan looks at and how that can assist in making a diagnosis and decide management of your patients. So please also remember that you can contact any of our nuclear medicine team anytime you have a question. Just give us a call at Lake Imaging. And thanks again for listening, and I can take some questions now if there are any.
One question: what dose of radiation does SPECT/CT expose a patient to?
So the amount, so basically what we do with the SPECT CT, so we don't do a whole body SPECT CT on every patient. We choose carefully if the patient would benefit from a SPECT CT, and the amount of radiation is very, very, very small. And we also only localize that to the areas where we're trying to get a better anatomic localization. So sometimes it's enough to just do the SPECT scan without the CT. So we don't kind of just use that on every patient, but we try to use it in areas where it makes a difference. So for example, if you looking at the cervical spine, you're trying to find the facet that's abnormal, you want to make sure you get the right spot if you're going to be injecting that. So I mean, in terms of how much dose, probably equivalent to maybe a chest X-ray or something like that. In terms of dose, we can dial it up and down based on how much detail we want.
Thanks, Stefan. There's no questions, no more questions at this stage. If there any comes in the next 5 or 10 minutes, we can get them answered at the end. So I will now hand over to the third speaker, Maywash Rehan. Thank you.
Helene, there is a couple of questions that have come in for Stefan. So while we try and sort out what's happening on Maywash's end, do you want to ask those questions to Stefan?
Yes, I shall. So Stefan, so in referring, do we state SPECT and leave the CT part up to you based on clinical setting?
Yes, so basically everything that I talked about, all these different aspects that we have are part of the bone scan. So you don't need to specifically state that. So basically we make the decision at the point of where the patient comes in. We do the kind of the 2D bone scan that everybody's used to, looking at the whole body imaging or specific imaging, and then we will add on the SPECT CT if we feel that it's necessary. So no need to specifically ask for that. So that's done automatically.
And query Medicare rates / costs?
Pretty much all nuclear medicine scans, as in terms of bone scan, are Medicare rebate, fully Medicare rebatable. So you know, that, yeah, especially the type of bone scan for the imaging of these painful conditions that I've presented should be fully Medicare rebatable.
And the incidence of allergy?
Almost unheard of, because what we basically inject is trace amounts of you know, basically what we consider little like salts, and you know, so personally I have not seen one single reaction to the radioactive substance or the actual physiologic substance given the small amount, but never say never. But if a patient is allergic, for example, CT or MRI contrast, that does not mean that they're going to be to have any kind of allergy to the nuclear medicine compounds.
And is it suitable for pediatric patients?
Absolutely. It's quite often used in pediatrics. And that can be used to, you know, sometimes in diagnosis of things like osteomyelitis. And of course, you have to remember that nuclear medicine isn't just about, I mean, I talk specifically about imaging of bone, but we can image many different things. So, you know, from imaging the renal tract to hepatobiliary abnormalities in children, for example, with biliary atresia or problems with kidneys, or you know, all different kinds of things. So it's used there. It's done at the, I mean, for younger children, it's always better for these to be done at the children's hospital, just because they have a better environment. Often patients have to lie on the camera for quite some time, and that can, you know, if you have better facilities around, that's good for kids, such as play therapy and all that. But yeah, so anyone that's kind of a reasonable age can be done with us, but yeah, it's quite often used in pediatrics.
Hi everyone, I'm Dr. Maywash Rehan, and I'm working at Lake Imaging Warrnambool. I'm going to discuss the role of cross-sectional imaging in the evaluation of the most common cause of abdominal pain and the most common surgical emergency in children with suspected cases of acute appendicitis. So we're going to briefly review the anatomy, pathogenesis, and the clinical presentation of acute appendicitis, the imaging features and relative advantages and disadvantages of CT scan and MRI, and identify the important technical factors in the performance of these modalities in children with suspected acute appendicitis. So it's the most common condition, as we all know, which requires emergent abdominal surgery in childhood. The clinical diagnosis of which is often not straightforward, because approximately 1/3 of children with this condition have atypical clinical findings, and the delayed diagnosis has serious consequences, including appendiceal perforation, abscess formation, bowel obstruction, and even death, which is less than 1%, although. Well, this cross-sectional imaging with ultrasound and CT scan have proved useful for the evaluation of suspected cases of acute appendicitis. And the negative appendectomy rates have decreased significantly from 20 to 25% to more recently 4%. However, the higher rates are noted in young children and female adolescents. Its incidence is 11 per 10,000 people per year in US, and according to one of the study in Australia conducted in New South Wales in 2018, there are 14 cases per 100,000 under 16 years of age, and most commonly it is in children between 10 to 19 years. So the appendix is it's a blind pouch. It arises from the posterior medial aspect of the cecum, which is 2 to 3 centimeter inferior to the ileocecal valve. Well, that's the base of the cecum, which is the stable, and it's the tip of the base of the appendix, which is stable, and it's the tip of the appendix that can have a variable position within the abdominal cavity, as you can see. So the most frequent is the retrocecal, which is 65 to 70%, and then the pelvic, and then pre and post ileal, which is about 5%. For just brief thing about the pathogenesis, the obstruction of the appendiceal lumen could be because of the lymphoid hyperplasia, fecolith, or appendicolith, and to some extent to foreign bodies, and Crohn's disease can lead to the buildup of fluid, secondary infection, and which finally goes to the ischemia and necrosis of the appendix. There are several clinical scores which the clinicians are using that have been developed that combine the clinical findings, examination factors with laboratory findings to better risk stratify the individuals with suspected appendicitis, which is the most commonly used is the Alvarado score, which is also known by the mnemonic ventrals. Well, with the diagnostic imaging, we do have a multi-modality approach. The plain X-ray is which is the most frequently and most commonly asked investigation, or people think that that's the first line of investigation. However, it gives non-specific findings in 68%, and its sensitivity is as low as 0%. So the first line of investigation in most of the cases is ultrasound. It carries a sensitivity of 66 to 100%. The CT scan, which is this above 90%, and the MR is also having the sensitivity of above 95%. However, the role of MR is yet to be discussed, and there are several factors, there are several things to be seen before ordering an MRI. So the goals of imaging is to facilitate an earlier diagnosis of acute appendicitis or the other conditions that can mimic, reduce negative laparotomy and perforation rates, and reduce the intensity and cost of care. X-rays, they can be beneficial in cases of perforated appendix or in cases of bowel obstruction. However, they can give some idea of some inflammation going on within the abdomen, as this image it's the frontal projection, it's in erect position, and it is showing an abnormal gaseous pattern, which is due to the dilated small intestinal loops in the mid and the superior abdomen without any configuration of an obstructive pattern, and it suggests ileus, which is mostly related to some inflammatory condition within the abdomen. This image is a focused image in the right lower quadrant, and it is showing a calcific density which is projecting over the right iliac bone, and it is surrounded by a fecal matter within the cecum. So this image do lead to the suspicion of acute appendicitis, and it do predict that the sensitivity is more than 90% for this. Now, ultrasound is the graded compression ultrasound. Graded compression ultrasound is the gradually increasing pressure of the ultrasound that helps to displace the bowel so that to visualize the appendix. The features are the most common and most highly specific feature is the aperistaltic non-compressible dilated appendix. It's increased peripheral vascularization, appendicolith, echogenic prominent pericecal fat, and periappendiceal fluid collection. So the appendicitis criteria is the maximum outer diameter should be, if it is between less than 6 millimeters, but that's normal. But if it is more than 8 millimeters, that's the diagnostic for appendicitis. However, if it is between 6 to 8 mm, it's borderline or equivocal. This is the ultrasound image in that's the sagittal plane with which we can delineate the entire appendix, and that's the blind ending loop. So that's the outer wall. We measure the appendix from outer wall to outer walls, and it should be more than 8 mm. And so here there is on the right hand side is a axial image which is showing a target sign. Well, that's it. This image is showing the graded. This is the graded compression ultrasound image, and it is not showing the compression or the collapse of the viscus as it is inflamed, and rather it is showing the target sign. So this image is the normal appendix, and in this we can see that it is showing the compression and the collapse of the appendix, which is a normal appendix. And here also it's not the target sign, it's just showing you the collapse or the compression effect of the ultrasound probe. Doppler findings are again carries a high sensitivity and specificity. Well, so this is the normal appendiceal flow, which is called as a type 1 or dot flow. It is defined as a punctate or a dispersed signals. As we can see, it's not a continuous, it's just a punctate, or in easy language, it's just a minimal vascularity, which we can see in the normal appendix. And this can be compared to this inflamed appendix, which is showing a continuous flow, and it is called as a type 2 flow, and which is defined as a continuous linear and curvilinear signal. So that's this is again showing the continuous flow. So there is another supporting factor for the appendicitis, which is the appendicolith, and it can be shown as a bright structure within the appendiceal lumen. Well, that's the dilated appendiceal lumen. There is another feature of appendicitis which is the supporting feature, and that's the increased surrounding echogenicity of the surrounding tissue. Mesentery, and that is the periappendiceal inflammatory condition. So CT scan is used very frequently as well. Well, when the ultrasound findings are equivocal or non-diagnostic, then and there are high suspicion of appendicitis, there is another modality which is the CT scan, and we can have a better view of and the delineation of appendix and the other abdominal structures with the CT scan. Well, these are the two images showing the normal cecal appendix. The air is dark or the black on CT scan. This is the contrast enhanced with the IV and oral contrast enhanced CT scan image. It is focusing the right iliac fossa, and this structure, the black, it is the air-filled structure with a blind end is the normal appendix. And on the right hand side, this structure is again, it's an appendix which is showing the contrast within its lumen, and it is not dilated or distended, not showing any thickness of the bowel wall. So that's the normal appendix visualization by CT. The features in the CT that we see is the dilated appendix with distended lumen, which is again, it's more than 6 to 8 mm, thickened and enhancing walls. This CT image is showing the dilated image. It's a coronal contrast enhanced CT image. In the hyperdense structure, just at the tip is the appendical lid, and there is a significantly distended appendix with some periappendiceal fat stranding is also seen in the surrounding. Another feature is the thickening of the cecal apex. Well, these are the supporting evidences and the features. Apart from the inflamed appendix, there may be a thickening of the cecal apex, and which is goes up to the 80% of the cases. We can see this thickening of the cecal apex. Then the appendical lid, we can see that it's the mildly dilated appendix, which is and showing the appendical lid within it, and it is a fluid fill. Well, then the periappendiceal inflammation, which is seen in this coronal image, as that there is, again, it's a dilated appendix, and there is some fat stranding within the surrounding mesentery. That then this one is the axial image. It's just showing the tip of the appendix, and there is a significant periappendiceal fat stranding. This is the cornal fascia, which is thickened, and there is some fluid in the right iliac fossa as well. The complications of the appendix can also be seen with these modalities, as it can be there can be perforation, periappendiceal abscess, peritonitis, bowel obstruction, and that can lead to gangrenous appendicitis. So the perforation, in the perforation, where we might not be able to delineate the appendix, and it's just there can be fat stranding, which is in the right iliac fossa, and there is an appendical lid, which in this image, this is the axial image, post contrast enhanced image. This is and in this we can see there is an appendical lid with a significant surrounding fatty infiltration, and we can't delineate the appendiceal outline. We can't outline the appendix in this, and this was confirmed on surgery. Another case which is showing the periappendiceal abscess, which is extending from the cecum, and it is infiltrating the psoas muscle. Well, the left psoas muscle is very clearly seen, and we can clearly identify. However, in the right side, we see that there is an abscess which is infiltrating the periappendiceal, the psoas muscle. So now there are advantages and pitfalls of these modalities. For the ultrasound, the most the advantages would be the lower cost, and it's of course the lack of ionizing radiation, and it definitely provide dynamic information through graded compression, and it do delineate gynecological diseases, or you can find the other mimickers like urolithiasis and ovarian cyst. But there are certain pitfalls, false negatives. The operator dependency. Then there can be a non-visualization of appendix, could be related to obesity because there is inability to adequately compress. Then if there is the retrocecal appendix, that's again difficult. Sometimes it do give difficulty. in visualization, and if there is perforation already, so there will be no proper delineation of appendix, and it's just an inflammatory inflammatory tissues there. Then some of the time there is tip appendicitis. Well, the tip appendicitis is if only the proximal part of the appendix was imaged and the tip was not or could not delineate the appendix properly throughout its entire length. So that can be another pitfall, because in the early stages the inflammation starts from the tip. So that has to be taken under consideration. CT scan again has its advantages, like less operator dependency, of course, and it has enhanced delineation of disease extent if there are cases of perforated appendicitis. Then in cases of obese patients where the ultrasound compression won't work, in those cases it's beneficial to get a CT scan done. Then it is precisely delineate the location and extent of the fluid collection that needs drainage procedures. So that in that case the CT scan would definitely help. However, the pitfalls, it would be the overlapping range in the maximum appendiceal diameter between the normal and the inflamed appendices. So in that cases, there's a secondary signs that the periappendiceal inflammatory changes would be considered. And then the inflamed appendix may be mistaken for an unopacified bowel loops. And again, the tip appendicitis, as we have discussed in the ultrasound. So another thing would be thin patients with poor intra-abdominal fat, which really lead to a difficult condition in the visualization of appendix. So there comes the ultrasound, which help in these situations. This is a case which is showing the unusual location of cecal appendix. And this appendix was seen in there's a patient come with right groin swelling and pain. And so with the CT, it was found to be an appendix within the inguinal hernia, and which is called as amine hernia. Well, MR provides a high spatial resolution, but however, there are some limiting factors to this massive implementation of this type of imaging, like its elevated cost, its low availability, long acquisition times, and movement artifact, and which leads to sedation in children, and its safety in pregnancy is yet to be is not yet declared. However, these are the MR images, and these images are showing the normal appendix. Well, these are the coronal T2 weighted image, and it is showing the normal appendix as a black structure here, the dark gray structure here. And then on the right side, it's the 14-year-old boy image. It's a coronal T2 weighted image, and it is showing an intraluminal fluid within the normal appendix. So that's the normal appendix in the MR. The features in the MR is almost the same as we can see in the other modalities, like in this image, this is the T2 weighted fat sat image, and it shows the dilated appendix, which is filled with fluid, and it is also showing the surrounding like periappendiceal fluid in this case. So that's the other case, which is again showing a dilated appendix. However, there is a dark structure or hypointense structure within the appendiceal lumen, and this is the appendicolith, which appeared as a dark or the hypointense structure. There are many differentials of with the mimickers of acute appendicitis. The most common mimicker in the pediatric age group is the mesenteric adenitis and the gastroenteritis. However, the other conditions like inflammatory bowel disease, Hinoch-Schondlin purpura, or ectopic pregnancy, they can be. There are many others as well, but these are the more important ones. So in the mesenteric adenitis is actually, it's the most common alternative condition, which is identified as negative appendectomy, and it is a benign inflammation of ileocolic lymph nodes. This is the CT, then the CT findings. It includes the enlargement of mesenteric lymph nodes and the thickening of the adjacent cecum and ileum and normal appendix. However, this is the ultrasound image on the right side, and it shows the enlarged ileocolic lymph nodes. So the enterocolitis is, it may occur in bacterial ileocecal, and these are the imaging studies which showed, these are the ultrasound images, and it showed thickening of the terminal ileum and cecum without inflammation of the surrounding fat. And there are moderate mesenteric adenopathy. These conditions, they won't show the appendix, like the inflamed appendix. The appendix in these conditions would be normal. So now coming to an end of this, just the brief talk, pediatric appendicitis remains the most common indication for urgent abdominal surgeries in children, and imaging with ultrasound and CT plays a crucial role in establishing an accurate diagnosis. There is broad variation in imaging techniques and diagnostic performance in each of these modalities. Yet when optimized, they can all yield excellent diagnostic results with minimum risk to the patient. A stepwise imaging approach that begins with graded compression ultrasound and proceeds to CT in selective cases is currently the best practice. Thanks.
Just one question. Should everyone with clinical appendicitis have some sort of imaging?
Ultrasound is the best imaging, well, because there are certain mimickers as well, as I have already talked about, especially in pediatrics. So better to get the lower cost and ultrasound if there is really high suspicion of appendicitis.
And how frequent are false negatives?
The false negatives, they are, I have already discussed about the conditions where these false negatives, because in normal body habitus, with good bowel prep, so the ultrasound can be, the sensitivity goes up to from as high as 80%. However, if there are factors that I've already discussed, like obesity, so we can consider CT as the first line of modality. So, yeah.
How often is CT requested?
It is, these days, it is very oftenly requested as to find out the other mimickers as well. And it depends on how high is the suspicion of appendicitis. And most of the times, the physicians, they do request as appendicitis versus mesenteric adenitis. So it all depends on the suspicion of the, how high is the suspicion.
Thank you. There doesn't appear to be any more questions at this stage. So I would just like to take this opportunity to thank all three presenters, three excellent presentations. So thank you so much. Please don't forget to give us your feedback on the webinar tonight. And if there's any topics on anything that you would like for the next year, just pop them in the topics request form, or if there's any radiology topics, pop them in, because I'm sure we'll have a radiology talk again next year. So thank you all for attending, and we'll see you at the next one. Bye.